Hi, it's Dr. Centeno, and thanks so much for joining me today. Regrettably, my office at home here has got a vicious backlight in the morning, but we'll have to deal with that. So anyway, got an interesting topic today. What we're going to talk about is I will expect to be a charged topic, right? And that is, we have lots and lots of patients who certainly tend to latch on to various MRI findings. And I certainly understand why that happens, right? Patients are suffering, they want an answer. And one of those is retroflexed DENS. So what that means is the DENS kind of goes backwards, and we'll get into that today. The good news is that the presence of a retroflexed DENS, based on a review of the literature, really doesn't mean that you need surgery. Now, that's good news, right? That doesn't necessarily mean, though, that most patients will be excited about that. And we're going to get into that today, but going to talk about retroflexed DENS, going to talk about why it probably means that you don't need surgery. And I'm going to support that concept with some research. So we're going to get a little in the weeds today, a little bit more than we do. At the same time, we'll get into, I think, a critical concept. And that critical concept is the idea that fixed deformities that are in the mild to moderate category on MRI by themselves don't mean much, but if you add instability in the mix, it's kind of like adding gasoline to a bonfire, which is what I discuss with my patients all the time. So let's see here. Let me go ahead and start sharing my screen here. Okay, got that going, and then we'll start the presentation here. Okay, so let's get into why most patients with retroflexed DENS don't need surgery. And then after that, I'm gonna answer questions, whether it's about this topic or anything else. This will be maybe 15 minutes, and then the last 45 minutes will just be answering questions. If you have a question, put it in the comment here. Also, do me a favor right now. If you want other patients to be able to find this content, and if you want to pay it forward in the CCI community, please like, subscribe, share, whichever platform you're on right now, because that's how people find this content. And that's how people can be given an opportunity to avoid surgery. And really, that's what we're all about here, is trying to find those patients that can avoid surgery and offer them a non-surgical alternative. And there are patients out there that absolutely need surgery, but also identifying those as well. But if you believe in that concept that patients should be given a shot or a chance at avoiding surgery, then please like, comment, share, subscribe, because that's how patients find this stuff. So this is really the case that got us here. And let me back up a little bit. So this was a patient that this last week I did a telemedicine on. And you can see on the left here, before surgery, got a lot going on here, right? Got a little bit of a retroflexed DENS, got a little bit of a Chiari 01 back here. There's clearly some mild compression of the brainstem here. It very much a stopper type effect, right? Not much cerebral spinal fluid is getting through there. And then you see this syrinx here, meaning this white stripe, and you're like, well, there's clearly some evidence of increased intracranial pressure, because that's what that syrinx in this situation probably represents. Okay, so the patient then went and got a Chiari decompression back here, a posterior fossa decompression. And so she went from lots of symptoms to more symptoms. The good news is that her syrinx went away. It's not there anymore. And now she's got some room in front of the spinal cord and brainstem and behind as well. So there's all sorts of CSF now pumping through there, but she's got more symptoms. So this is why I was seeing this patient, right? This patient was coming to me because what do I do now? I had this surgery and they now want to do either another bigger decompression or maybe a fusion. Can PICL help? And so the answer was, well, probably could help more before the surgery. After the surgery, it's a little bit dicey because parts and pieces have been removed that provide stabilization. That includes muscles in the back because of the Chiari decompression. So my ability to help didn't go up from the surgery. It went down from the surgery. So that really is what sparked today's presentation. In addition to that, I've seen lots of people online talking about retroflex dens as if by itself that means something. So we're going to get into that today. When I give presentations like this, I'm going to start putting this warning in here, don't shoot the messenger, meaning I went through the literature, this is what I found. And I understand that we've got patients that are suffering. They get told by a surgeon that, you see, this is the problem. If we take this out, it's going to be all better. And I understand how attractive that is to someone who's suffering. I also understand that many times you get told online, someone looks at your MRI. I've seen a lot of patients posting their MRIs online. Oh, you've got a retroflex dens. That's clearly causing your problem. Just get that surgically fixed and it'll all be better. So for those patients, this message may be a little off-putting, right? Because I'm going to show you why a retroflex dens by itself doesn't mean what many patients believe it means. But my job is to balance all of this. So I see patients that clearly need surgery, and I send them on to what I think are some of the best surgeons in the world. I also see a lot of patients that clearly don't need surgery, that we can more likely than not help without surgery. So my job is to balance these things and constantly look at the evidence here. What's the evidence in certain clinical situations that surgery is clearly needed versus the evidence that something like a PICL would be a better fit because there isn't much evidence that what they're operating on is causing the symptoms. So that's my job, and I take it very seriously. And if you're a patient of mine, you know I take that very seriously. So what is a retroflex dens? You can see on the left here that this dens goes sort of straight up and down. And you can see on the right here that this dens tends to cant backwards. And it's that backwards dens, retroflexion, meaning flexed backwards, that we're talking about today. And you can see that what that can do is that it tends to move the dens closer to the upper spinal cord and medulla. So that's the general concept, that with other things, you may get compression of the upper spinal cord and medulla if you have a retroflex dens. Now, there's two measurements out there. Neither one of them are perfect. One is a clivoaxial angle, or CXA, also called a clivocanal angle, or CCA in the literature. And both of these kind of give some sense of how much that dens is retroflex. There's also a CLA, a cervical lordosis angle, which is basically putting a line here at the back of the dens and then drawing another line down to and aligning it with the lower cervical spine. And that gives some idea of the retroflexion of the dens. So those are the two angles we'll be talking about today, because they can both give some idea about whether or not the dens is actually retroflexed or bent backwards. Now, the first thing you should know if you've been told you have a retroflexed dens is that your lordosis, or the curvature in your neck, makes a big difference. So in the middle here, we see a more normal curvature. It's not perfect, but it's more normal. And there's our retroflexed dens. If we increase the curvature going to the left here, we see that we are increasing the retroflexion of the dens. If we go off to the right here, then we're decreasing the lordosis, or decreasing the curvature, and we're decreasing the retroflexion of the dens. So if you've got a retroflex dens, the first thing you should do is work hard on your posture. Get with someone like Todd Ball online and start working on that posture, because that can make a difference in whether or not that dens is poking into the brainstem and the spinal cord. So I'm going to give you the conclusion of the literature review before we start, and then I'm going to give it to you again. In adults without severe CCJ deformities, there is no difference in dens retroflexion, meaning the degree to that dens goes backwards, in asymptomatic controls versus patients. In other words, you cannot look at someone's MRI and say, aha, that's a retroflex dens. That guy has symptoms. Over here, here's another patient without one. That patient will not have symptoms. Doesn't work. So if that doesn't work, the idea that we can do surgery based on a retroflex dens doesn't hold water, doesn't make sense. So before we dive deep here, we have to get into some definitions. The first is, what is Chiari malformation? I think most of us that are in this community know that. That's where the back of the brain tends to go below the foramen magnum here. But the thing to understand with Chiari is that there are people out there with a Chiari 0 and a Chiari 1 without any symptoms who are living normal lives. Now, that's a shocker to most Chiari patients, because they have been told that their Chiari malformation is what's causing their symptoms. But if there can be people out there with Chiari 0s and 1s who don't have symptoms, then that gets called into question. And I will go ahead at the end of this, I share the link for a video, and I'll put that link in the description here as well, where you can click on that link and you can go to that Facebook Live discussion for Chiari. But we're going to stay laser focused today on the concept of a retroflex dens. So Chamberlain's line, and this is the idea that the dens migrates upwards, and that this can put pressure on the upper spinal cord and brainstem. So that's a line going from the hard palate to the back of the foramen magnum here, or the back of the skull. And the idea is that the dens will poke through that line or violate that line. And once the dens violates that line, it could be putting some pressure on the upper spinal cord and or brainstem. The other thing to realize, in the study I'm going to show you, they have some patients with what are called BI1 and BI2, or basilar invagination types 1 and 2. At the end of the day, these are severe CCJ abnormalities. 99.5% of the patients I evaluate don't have these. 99.5% of the patients watching this video will not have these. So that's important to realize, that these are in a whole other world than the stuff that we tend to see with our CCI patients. And those are surgical things as a result. So you also need to understand the research on CCI metrics to really understand this topic. And that is the concept of data separation. And this may be a little bit more obscure if you didn't excel in science or math. But the idea is that if you've got two groups, the green group here of patients, and that's their values. And so that's one standard deviation from the mean, meaning that's most 2/3 of the patients. Ranges, there'll be some ranges that are outside of that. And then the red group on the right here, so the green groups here, These are our people with no symptoms, and then the red group with symptoms. Now, this is this represents the range within the standard deviation. And then this represents the range within standard deviation. The little line is the mean. So if you've got good separation between these two, then great. We can say in this particular case, forgetting about what these numbers mean, you can say, well, if someone's got a 0.2, they're clearly normal, a negative 0.2. And if someone's got a positive 0.3, they're clearly abnormal, meaning you can probably use this to predict whether someone has symptoms. But if you get something like what you see on the bottom, where those standard deviations and means overlap to a significant degree, it's a mess. You don't know whether or not someone with a 0 is in the asymptomatic group or in the symptomatic group. Same thing with a plus 0.1, even a plus 0.2. So what you're going to see on the bottom is a mess. It can't be used to predict anything about a value and whether a value predicts patient symptoms. So this is the study that I found. This is the best one I saw out there because these guys did a good job of trying to make sure they had an equal number of males and females. They tried to make sure that the patient ages were the same, and we're talking about patients now in their 40s. Some of the other studies that are out there include the odd pediatric patient or have more women than men, and women's metrics are different than male metrics. But this was the best one I could find. And ultimately, these guys took lots of different measurements. They did Chamberlain's line, they did Bogart's angle. But the two that you need to pay attention to here are this CXA, also called a CCA, clivus canal angle. Because again, remember we said that is the degree of retroversion. That determines how far that dens is going backwards. And the cervical lordosis angle, again, we said before, that determines how far that dens is going backwards. So bottom line is, if we look at those two, there's tremendous overlap here. This is junk data. You cannot use the normal, you can't separate out the normal patient group from the patients with symptoms. Can't separate out the normal patient group from the patients with symptoms. Meaning that the degree of retroversion has nothing to do with whether or not the patient has symptoms. So having a more retroverted dens here didn't make any difference because at the end of the day, it was also found in lots of people without symptoms. So again, I'm going to summarize what I told you initially. In adults without severe CCJ deformities, which is, again, 99.5% of the people watching this right now, there's no difference in dens retroflexion in people walking around out there, living their normal, happy lives versus bed-bound, severely symptomatic patients. In other words, you can't look at a retroflexed dens and MRI and decide that's causing symptoms. That is a logical fallacy to do that. And we all probably know at face value that's true, right? Meaning that I think patients who have retroflexed dens know that they were probably born that way and had no symptoms until one day they did have symptoms. So what changed? Well, oftentimes in our world, it's new instability that changed. But it also could be things like changes in posture. Most of the patients I come in are like this, even if they're young. Why? They do this all day, looking at their phones. As I already showed you, if you have a retroflexed dens, that's a really bad thing to do. It will make that retroflexed dens into something that can piss off your spinal cord. And then sometimes we see patients who have a spike in systemic inflammation. So maybe that's when they had COVID and that increased systemic inflammation. Or maybe that's when they had something else going on and that increased systemic inflammation. And that's enough to start that downward spiral. But something changed. And in most of the patients we see, it's new instability. So that leads us to a truism. Mild to moderate deformity alone doesn't cause symptoms, whether that's a retroflexed dens or a Chiari 0. Important to understand. But when we add instability into the mix is when we get symptoms. So if you've got a retroflexed dens plus instability, that retroflexed dens acts as an accelerant for symptoms. But if you don't have instability, then that retroflexed dens probably has nothing to do with why you have symptoms. And again, it means that if you have a retroflexed dens, then the solution is not to take out your dens surgically. The retroflexed dens isn't the problem. It's a retroflexed dens plus instability. So if we get rid of the instability, we put you back how you were before, no more symptoms. So that's critical to understand. So the best way to think of mild to moderate deformities like a retroflexed dens or Chiari 0 or 1 is by themselves. They're common in people who are out there living their lives without symptoms. But when you add instability into the mix, they act as an accelerant for symptoms. They add gasoline to that bonfire. So if you want to know more about Chiari 0 CTE or Chiari 1 and CCI, go to this YouTube link, and I'll try to put it in the description below, because that's how you can learn about symptomatic Chiari and CCI. So the same talk, but focus more on Chiari. So let's get to Q&A here. I hope that all worked. We had that one problem that one time. I think we look good here. So guys, it looks like some of you didn't see the slides advance. Yeah, see guys, I can't see the comments. Well, best I can do, guys, then is to go ahead and probably I'll just go ahead and record this separately and put it up online right after I get done with this. So it'll be on my YouTube channel. I apologize. This is now the second time that's happened. I don't know why that's occurring because I've never had those problems in the past with this. But anyway, let me get to answering questions since there's a bunch of questions, and then I'll go ahead and record this separately so you can see it all. But I apologize that seems to now be a thing, meaning it's happened once before here in the last month, and it seems to have happened for some patients here. Do me a favor, put a comment in there right now if you were able to see the slides advance. I want to know if it's something that's happening on my end, or is it something that's happening in general? Okay. Do me a favor, guys, put those comments in there so I can see if I got to fix that. So Erza couldn't see the slides advance. Anybody else want to jump in there? Okay. So I will go ahead and I'll fix that. I'll go ahead and do the slides again. I'll put it up on my YouTube channel. That will, I should probably be able to get that done right after this. So apologize, guys, but it'll be available soon. So let me get to some questions here. Hey, Dr. C, can PRP in the cervical helps with neuro symptoms? I don't know what that means, meaning that you would have to, I'd have to know what type of CCI you had, what kind of PRP injection were you talking about? Were you talking about a simple blind prolotherapy type treatment with PRP? Are you talking about a fluoro-guided injection into certain upper neck joints with contrast conformation? Are you talking about PICL? So impossible really for me to answer that question without that kind of information. So the good place to start would be, what kind of CCI do you have? Happy New Year, Rishi. Let's see here. Submitted advance by John. Hi, doctor. Hypothetically, if someone who had no CCI or a lateral overhang whatsoever got a PICL, what would happen to them? Would they not have much of a recovery at all because the ligaments aren't damaged? I think it's important to recognize that we're looking at DMX overhang solely as a surrogate for a problem, right? DMX overhang allows us to see that. And that doesn't mean that there aren't some patients that still have some instability that are causing symptoms that might not have, where it might not be shown on a DMX. It might show up on an upright MRI, that kind of thing. In addition, it might not show up on either, but someone still has some microinstability leading to symptoms because of what's going on. Now, in a PICL, we're also treating lots of posterior things. So, for instance, if the symptoms were mostly coming from the 0, 1, and 1, 2 facet joints, and we're injecting those, then that's, that person may get quite a bit of relief. Amen. What causes body tingling in people with CCI, brainstem compression? That can be due to lots of different things. It can be due to irritation of the dura, due to craniocervical instability. It can be due to irritation of the upper spinal cord itself. If there's some compression there, it can be due to overactive scalene muscles, etc. Submitted advance by John Gardner. What are your thoughts on adhesion release, doctors, for SCMs, neck, and traps if you have CCI? I think anything you can do to increase your muscular stability will be helpful. So if you've got adhesions between those things and those muscles aren't working, then that could be helpful for you. But do I think it's going to solve the CCI in most of the patients that I see? I don't. Elias, my atlas, after a few years of multiple type chiropractic treatments, doesn't seem to want to stay in place. Can surgery be a solution? Surgery wouldn't be your first choice, right? Because we often talk about that here, that surgery is going to more likely than not lead to substantial other subset of problems. So depending on the type of CCI you have, you would probably want to try injection therapy first, but you have to get typed. We have to know which of those 8 types of CCI you have in order to know what needs to be treated. So you don't have a diagnosis until you know which of those 8 types you have. Rishi, would taking antidepressant drugs to treat nerve pain interfere with PICL healing? No, it shouldn't interfere at all, Rishi. It's been advanced by John. If a patient is type 2, can do push-ups, sit-ups, play basketball, would you say they're fully recovered with just one PICL? It's pretty good. I'd hit the rehab hard and then go from there. So I would say probably you don't need another procedure given that description. Now, there may be other things I don't know there. Maybe, they can do all that, but they've got symptoms, or they can do all that, but every time they turn their head to the left, when someone calls them, they go down in bed for a week. So there may be more other pieces. Yeah, I saw that there, Andrea. Sorry about that. I will get this out to you guys here. I've had AARD and CXA 134, BDI of 3, severe case, bedroom. What do you think I have? Just AAI or both AI, CCI? I have 100 symptoms. Well, the CXA 134, I need to know in context. I can only tell you that when we start to get concerned when the CXA goes into the sub 125 region, but that can depend on how much room there is with that CXA. So, and then if you mean you have a BDI, a translational BDI, the cutoff for an abnormal translational BDI, which is the BDI from flexion to extension, is 4. So that would be below that. But again, that BDI can change depending on how much room there is. So those numbers by themselves don't represent abnormalities or CCI, but I don't know the clinical context. Steve, I know you recommend getting AO adjustment soon after a PICL. My AO adjustment atlas a week after. Wanted more time to pass for adjusting other cervical vertebrae. I can feel my C2 and C5 are misaligned and cause significant pain. My AO was concerned adjusting the cervical percussion, adjusting instrument too soon may interfere with the healing process. You know, Steve, if they're doing the same type of very low level adjustments with instrument adjusting, where it's very low force, I wouldn't have a concern with the lower cervical spine. Some advanced by Harry Winston is possible retroflex stents to ever heal on its own. Again, Harry, after this, I hope you know that a retroflex stents is not an abnormality, meaning a retroflex stents by itself doesn't have any clinical meaning. So there's no reason to heal it. Now, it can set you up for more symptoms if you have instability plus a retroflex stents, but our goal should never be to do anything about the retroflex stents. Our goal should be to change the instability. Ian, if you have an acute CXA without a retroflex stents, does that make it more or less likely to be CCI? Depends on what your CXA is. Again, Ian, be careful there because most of the patients I see believe that, for instance, a 134 CXA is wildly abnormal. It's not. Also, my neurosurgeon advises I have somewhat of a flat skull base, which he implies causes the acute CXA measurement rather than being CCI. Yeah, well, I think your neurosurgeon is pretty smart then because, you know, that's an important thing to consider, right? Is the CXA I'm seeing actually related to instability where the skull is falling forward, or is it more related to just the way that person was built? And is it causing enough compression or stretching of the spinal cord for the physician to be concerned? So I think that's a pretty smart neurosurgeon. They're taking a conservative approach, which is unusual. We often see the opposite, right? Where we get a very aggressive surgical approach. NOS, back and low back pain, heavy and painful legs. Is that due to AAI or L3-4 stenosis? I can't answer that question. I don't know. I would need clinical information to answer that. I would need a lot more clinical information than just that. Important topic. Thank you for going into the detail on this. Can you have your ITT? Yes, I will, for sure. There are attachments from CCJ directly to aponeurosis, similar to how myodural bridge attaches from dura to suboccipitals. There are attachments from the CCJ directly to the aponeurosis. I'm not quite sure what you mean there by the aponeurosis, meaning that there are fascial connections into the supraspinous ligament, and then some connection from the supraspinous ligament and through the interspinous ligament into the ligamentum flavum and PAOM. So you could say that you could have fascial effects on the dura through that connection. So if there are substantial fascial issues, you could certainly try to treat those fascial issues and to see if that helps. Realize the biggest problem we see with the myodural bridge is it's not functioning. And there's a lack of normal tension on the myodural bridge. It's not, I think what you're contemplating is that it's usually the opposite. AT, last week you spoke with Greg about how you notice areas that have both hypomobility and hypermobility at the same time. Can you elaborate on this? Sure. So we will frequently see, I think what Greg was talking about was the upper cervical spine and how the upper cervical spine in certain directions has hypomobility. In other directions, it may be hypermobile. So the joint can't move into the hypomobile range, so it tends to prefer the hypermobile range, I think is what he was talking about. Doc, continue aggressively incorporating extension with in-office traction, feel a bit more unstable and ill-flared, but able to tolerate. We'll provide update picture. Okay, sounds great. While PICL or PRP procedure, can you see the level of damage on the ligaments, meaning with those? You can. It depends on, well, you have to, number one, use imaging. So, for instance, if you're using ultrasound, you can sometimes see how the injection will blow apart the ligament, in which case that shows you that the ligament is damaged or friable. If you're using contrast, you can see similar things. So the answer is you can get some idea of what's going on that way. Let's see. Met with a spine specialist, told me they don't deal with dizziness. He said that another specialist for the head. How come so few have been considered coming from the neck? Yeah, it's a good question. I just think that that doctor hasn't really looked at that research very well. And it's not a common complaint they get, so they probably don't have a feel that they need to really understand it very well. So that's probably why you're seeing what you're seeing. But remember, as we often talk about, the upper cervical spine causes dizziness symptoms. Let's see here. Use of HDS does better with dextrose, consistent with PRP when ligaments versus joints are the trouble. How do you distinguish between those two? Yeah, so in my experience for hypermobile EDS patients, dextrose prolotherapy tends to do better than PRP for their ligaments. PRP tends to do a heck of a lot better for their joints. In normal ligament patients, we tend to see that PRP does better than prolotherapy, and for ligaments, and then same thing, PRP is better in their joints than dextrose prolotherapy. So I'm not quite sure what the question is. How do you distinguish between these two? Hopefully I answered it there. Andrea, Dr. Centeno, is it true that CXA and Grabb-Oakes measurement is only relevant when done on upright imaging? I think both of them are very importantly done on upright imaging, meaning that you can still see an abnormal CXA on a supine MRI. You can still see an abnormal Grabb-Oakes on a supine MRI. But I think you're getting a more functional look at what's happening on upright MRI. And also realize that an upright MRI, the standards change. So now we're up to a Grabb-Oakes of 10, still being normal. And we're up to a CXA on the low side, again, around 125, as I had discussed before. So again, if we're talking about a Grabb-Oakes of 9 on an upright MRI, it's probably not abnormal. If we're talking about a CXA of 134 on an upright MRI, it's probably not abnormal. Let's see here. I have type 2B, Chiari 0, retroflexed DENS, and HEDS scheduled for PICL soon. Everybody is telling me my scans are normal, though I had abnormal DMX that you confirmed. You can see instability. I have a neuro ENT doing eval who found signs of BPPV on the left and right ear weakness on the right. Can any of these ear problems related to a separate issue? Yeah, so BPPV is nothing, meaning it's a box in which we put patients when we really don't know what's causing their dizziness. Now, if we're talking about weakness, meaning cranial nerve 8 problems, then that's possible that it could be causing the dizziness. It's also possible it could be coming from your upper neck. There are tests that you can do to try to figure that out, but most ENT doctors won't be doing that kind of test. Tressa, it's certainly something, if you just want to send me a copy of your ENT report, I can try to understand all that for you. Dr. Schultz, thank you, John. In addition, it would be possible to contact your clinic for evaluation of which types of CCI. Yeah, so that's done during a telemedicine visit. So we do a pre-screening for the telemedicine to make sure it's likely that you have CCI or you have the right imaging for us to tell. And then assuming you get past the pre-screen, then we can do a telemedicine evaluation, and I'll be able to give you a type of CCI and talk about various treatment options then. I have bilateral dehiscence of the posterior semicircular canals also. Again, I think it's best to just send me the ENT report so I can look at it and try to interpret what they mean and whether or not there could be some connection there. Angel, getting a DMX soon. Think there's a legitimate chance I have CCI, but it could also be just an injured facet joint affecting my balance or something you can help with. Yeah, so again, that's going to be an upper cervical facet, most commonly 01, 12, 23. If it's 2-3, that's a facet you can get injected at a lot of different places with PRP, under X-ray guidance, contrast confirmation, etc. If it is 01 and 12, then that's something you have to come to Colorado for. Snow mass. If jaw feels like suddenly hanging and sharp pain down to the SCMs to the chest, would that be potentially injurious to SCM, pterygoid, or styloid? Would TMJ MRI show injection needs to be? TMJ MRI is probably not going to be all that helpful. It'll probably only show us if there's degenerative changes in the TMJ joint. But if you're having pain there, then the best thing to do would be a hands-on exam so we can localize what's going on there. But it sounds like all of that is overload of the anterior strap musculature. So what is the anterior strap musculature? The anterior strap musculature is the muscles up front that are causing stability. And if they get overloaded, that overload can lead to problems in the TMJ. You can also get problems in the strap muscles down here. So that's the whole anterior stability system. And so, for example, we frequently see problems in the anterior stability system in CCI patients. Doesn't mean that that's what's causing this. Andra, in addition, possible country clinical, I got all that already. How bad is a translational BAI of 5 to 6? Well, that's definitely abnormal. The cutoff there is 4. It's the cutoff we use, and that's the cutoff that was recently reflected by Nicholson et al. So Henderson is the first, Dr. Henderson, the surgeon, is the first person to suggest 4 as a cutoff. Again, realize that's different than the online cutoff, right? There's lots of patients out there with a BAI of 2 who have been told that's abnormal online. But if you actually look at the surgeon that proposed translational BAI, what he proposed was up to 4 being normal. If you look at the Nicholson et al. Upright flexion extension MRI paper, that was mirrored 4 as being abnormal. So BAI of 5 to 6 is abnormal. It means there's a type 1C skull sliding type instability. Natasha, after a client sees you for initial consult, you provide client with your interpretation. Would you liaise with the client's Canadian GP if needed? Sure. Yeah. I mean, generally, if there's a reason to do that, I'm always happy to do it. Just realize that that reason has to be clinical. And what I mean by that is I'm not trying, I wouldn't be willing to try to convince some Canadian GP to try to cover what we do. Because that's not really going to happen. So that's not a good use of my time. I'd rather use that time to help other patients. But if there's something clinical that needs to happen, I'll give an example. I have a patient who needs surgery, and I've been liaising with her GP and husband all weekend. We opted not to treat her because her ADI was far too big. But that, even though I never treated her, I still have been communicating all weekend with her family doctor, her surgeons, ER doctor, etc., trying to give them some sense of what's going on and some sense of what I saw so that they can make the best clinical decision for that patient. Thanks, Steve. Asthma. Hello, Dr. Centeno. What's the difference between a subluxation and the medical term one used by chiropractors? Yeah, they're very different. So a subluxation in the medical world means more like a dislocation. It means that bones are so out of place that you can easily see it on an x-ray. A subluxation complex in the chiropractic world is very different. It means that the bones are slightly out of place. Oftentimes, a medical doctor would say that's just normal variation. So they're very different things. Having said that, there's been a tremendous amount of research on chiropractic over the last number of years that talks about it's quite helpful for a lot of patients. Chiropractors are certainly onto something, and I see it a lot of times in my patients as well. Cassian, is retroflexed dens likely congenitally short pedicles, and that it only becomes problems when there is acquired instability? Again, we talked, just in discussion today, right? What we talked about was the idea that a retroflexed dens by itself doesn't really mean much. You can't use it to decide if you've got or if you've got symptoms. Now, the concept of where symptoms get generated is a retroflexed dens plus instability. As far as having congenitally short pedicles, that could determine, for instance, how big the spinal canal is, and hence that might be an important thing to know. So it might make the retroflexed dens more important. But again, a lot of that depends on looking at the whole clinical picture. Andrea, could you kind of say more about the utility of gentle craniosacral treatment, 0-3 adjustments in the hands of a skilled practitioner, the weeks following PICL? Yeah, I've got no problem with that at all. That's very similar to the upper cervical chiropractic that many of our patients go right back pursuing after a PICL. Charmaine, Hopkins doing shear wave elastography too, and then you got cut off, Charmaine. I'll see if it's picked up down here maybe. If it picked it up down here. Have you explored using ultrasound elastography to measure spinal cord tension? It's going to be fraught with all sorts of problems, meaning that in order to get a ultrasound signal into that area, it's going to be super dicey, meaning that you're going to have windows in which you can get ultrasound in and windows where there aren't. What I mean by that is that there's not a lot of room between the bones, and the only way ultrasound can get in is through the bones. It doesn't go through bone. It bounces off of bone. So I would suspect that you could probably do that in the right thin patients, the thinner the better, who have a certain type of anatomy where there's not a lot of bone in the way. So let's say that patient's going to be younger. Hypermobile patients would be perfect because you can really bend them quite a bit to open that up as much as you could. But that means that you're probably limiting your ability to measure that in maybe 1 out of 4 patients who would want that measurement. And for 3 out of 4, it's going to be a dicey proposition at best. So I don't think that's going to be a great answer for trying to say whether or not someone has spinal cord tension because of the fact that it's going to be really hard to see. And, especially in America, right, where we've got a very high prevalence of obesity, you get a heavy patient and all bets are off. You're not able to do any of that stuff. So probably not the best tool to look at that. Stone mass with x-ray worth getting to see effects of effusions in 1 through 3 over 6 months. Probably not, meaning if there was an effusion, that's an MRI finding. an MRI would probably be much, much better. And just so that patients know, effusion means swelling. Tanya, I was diagnosed with expanded empty sella, tear of the posterior PLL, crowded posterior cranial fossa, mild Chiari, C1, vert impinging on bilateral jugular vein, bilateral jugular compression, recommends right jugular and moving stylo, recommend pure. Yeah, Tanya, most of these things are not abnormal, so it's hard for me to comment, right? A partially empty sella is actually a bigger deal than a empty sella. It's hard to make the diagnosis of a tear of the posterior longitudinal ligament without something like a 1.5 or 3 Tesla MRI with thin cuts. You can't make that diagnosis, for instance, on an upright MRI. The imaging isn't good enough. Again, as we talked about, Chiari malformation, 0 to 1, probably not a big deal and probably not abnormal. C1 vertebral impinging on the bilateral jugular vein, or C1 vertebra impinging on the bilateral jugular vein. Jugular vein impingement is common. So about 1 in 3 people walking around out there has bilateral severe jugular vein compression and no symptoms. So that's a hard one to say if that's causing your symptoms. So again, I certainly, if that's all I knew, I wouldn't recommend getting a jugular vein decompression. But there may be other things I don't know here. So again, best thing to do is a telemedicine evaluation with one of the doctors in our clinic to try to see if all of this equals something that clearly requires surgery or not. And then, the biggest question to ask here would be, is there craniocervical instability? If so, what type? Which one of those 8 types is it? Because without knowing which one of those 8 types is it, I can't tell you anything. So you have to get typed for your CCI to figure all of this out. But I will say that it's rarely true that getting a jugular vein decompression is the first step. Because once you do that, you destabilize the anterior cervical spine. So in the vast majority of patients I see with similar issues, we don't recommend that they get their jugular vein decompressed because that's going to cause additional instability. So all of that has got to be looked at in context. Elizabeth, inclusive of my retroflex DENS, you successfully treating with PICL, which has helped my instability and pain management. Sudo, led to produce that my rectus capitis posterior monitor is completely ruptured. That's a tough one to see on ultrasound, Elizabeth. So happy to take a look at that, meaning that it's generally hard to visualize that. But thank you for bringing that up. Again, treating the instability with a patient who has a retroflex DENS can cause the patient to improve. And you don't need to cut out the retroflex DENS for the most part. Jay, hi, doctor. I did schedule the beginning of March. Thank you. Are there any acceptable strengthening techniques you recommend? Pre-PICL. Yeah, I'd recommend you get with Todd Ball. I think if you look up back on my Facebook Lives, go backwards, I think it's 2, and you'll see Todd Ball there. And he would be the person to get with to do some prehab prior to PICL. KCN, if a patient requested PRP rather than BMA for the PICL, would agree to do so? I would not. No. Doesn't make any sense to me. PRP is not going to work as well as BMC. So we would definitely refuse to do that. So you would have to go elsewhere if you wanted something like that, simply because BMC works dramatically better than PRP for ligament healing. I think I'm the only human on earth that's ever published on BMC for ligament healing, meaning we've published multiple papers now on ACL. I don't know of another human being who's published on injecting into the ACL with bone marrow concentrate. So I would be the world's expert on that topic. So it wouldn't make any sense to the world's expert to put in PRP when we could use BMC. Andra, would you recommend doing upright MRIs, neutral flexion extension with a route contrast, and why? Yeah, we need movement-based imaging. Craniocervical instability is a movement-based concept. So you're going to need movement-based imaging to try to see if that craniocervical instability is there. So that could be an upright MRI with flexion extension. That'll show certain kinds of CCI. Now, it's going to miss other kinds of CCI that a digital motion X-ray can pick up, but it's a great start. Casey, I meant, how can you distinguish the patient has a ligament problem versus a joint problem? Hands-on physical exam, MRI, history, symptoms, all of that's used to decide that. Natasha, I want to donate my brain spinal cord to research after I die, correlated with persons with history of concussion, CCI, research places. I don't really that are doing that kind of thing, although you may find, if you're talking about concussion or CTE, I think you can certainly find places that are doing research on brains. And it's usually football players, people who've had multiple concussions, people who've been in the military, have multiple blast injuries. So I know that kind of postmortem research exists, but I don't know of anything in this area at this point. Let's see. I think got that one already. Sure, Snowmass. Always try to do this. I apologize for the slides. I'm going to get that fixed. I think what I'll do next week is I'm going to open 2 windows because I can't see if the slides are advancing on my side because I can't see the comments once I'm in that mode. So I think I'm going to have to come up with a way to keep 2 windows open at once and see if the slides are advancing. Or maybe have my laptop over here. That's probably a better way to do it and view the presentation. So I'm going to get on that because now it's the second time it's happened. And it's certainly frustrating, I know, for you guys, and it's super frustrating for me. Charmaine, how would one determine whether signs of spinal cord tension are caudal or cranial? There isn't really a way to make that determination. You can do some physical exam things that might help. For example, this would be more cranial cord tension versus a straight leg raise would be more lumbosacral. So maybe on physical exam. Saclane, can disc bulge be treated with homeopathic medicine? One of my relatives got relieved after taking homeopathic medicine after failed physiotherapy. I think that would be very unlikely, and I think it's probably more likely that the disc bulge resolved on its own, which they do. Anel, who you're cheering for in the Super Bowl? I haven't even been paying attention to it. Been too crazy busy this last couple of months, so I have not paid attention to it. I wish I could, but I did not. In fact, I probably didn't even know that today's Super Bowl Sunday, if it is. Anel, is a more constant dizziness more consistent with CCS, facet injury rather than CCI? Yeah, I think, Anel, if you're not getting changeable symptoms when you're moving your head around, I think that constant dizziness is going to be a little bit more consistent with craniocervical syndrome than craniocervical instability. But then it comes down to, do you have instability? And what do we think? Is it look likely that instability is probably contributing? Snowmass, if there's congenital occipital condyle shortness, what issue does that cause in terms of scoliosis, bone spurs, CCI? If you actually go to that Chiari lecture that I will put in the new presentation I'm going to do hopefully right after this, then you can see information about congenital occipital condyle shortness and what that causes in terms of CCI. That's in that lecture, so that'd be a good one to review. Do you offer prolotherapy for HEDS? We do. Yeah, I treat a lot of HEDS patients. My focus is now more PICL. Lots of doctors in my clinic do multiple other things as well. So in my PICL patients, I'm constantly treating HEDS issues that are outside of the craniocervical area. Brent, there's someone I could find literature on 8 types of instability. Would love to be more about them. Yeah, Brent, if you go to my YouTube channel, just type in CCI types, that'll come up. We also have a peer-reviewed paper that we're writing for publication now. It's pretty much written outside of the data review, which is happening as I speak. So we can plug the data in, but that'll also go over that. But that takes a long time to wind its way through the system. So if you want to find that out now, go to my YouTube channel and just type in CCI types. Matt, is there any difference between ligament healing and ligament tightening? Does the diagnosis change the injection therapy type? They would be the same thing, basically. Tanya, thank you, Tanya. PICL scheduled for the day after Super Bowl. Yeah, I'm not paying attention, Lisa. I'm certainly not going to go out and get drunk or something for the Super Bowl. I got too many balls in the air, regrettably, or thankfully, really. Got to be thankful about stuff like that. Okay, guys, any more last-minute questions I can answer? If not, I will go ahead and try to make sure that I get that out for you because that's a little frustrating for me as well that the slides didn't advance. And then I think, like I said, next week I'm going to have to do a separate window, probably maybe have it up on my laptop so I can check on all of that. Andrea, seeing you in 2 weeks to arrange HES pelvic instability treatment at the same time. Do you prearrange this? Not necessarily. No, we do it pretty standardly. What I mean by that is we're always looking at the patient as a whole picture. Now, if we think you can't tolerate it, and we think it's going to be too much, then we may talk about that. But for the most part, it's frequently done, and it's something I'm constantly doing and looking for as I'm treating CCI patients. Snowman asks, how is cubital tunnel treated? Usually with higher dissection of the nerve with platelet growth factors under ultrasound. We've got pretty good data, for example, that PRP helps with nerve repair at this point. And so that's how it's usually treated. Okay, guys, thanks so much for watching. Again, I apologize for all the craziness, but I am going to go ahead and just record that and get it on my YouTube channel. So, if you check back here the next half hour, 40 minutes on my YouTube channel, then you can go ahead and find that. For those of you who don't know where my YouTube channel is, I am going to put that in the comments here. So it'll be available in the comments on this video so that you can just go right there. So see, and then I'm going to paste my YouTube channel. So you should start seeing my YouTube channel show up in your comments, no matter where you are, whether you're on Facebook or you're on YouTube. And I'll also probably try to post it to the Centeno-Schultz as well. So Centeno-Schultz Facebook. So guys, thanks so much for watching and have a great week. I will be here next weekend as well. And let me get to recording that for you guys so I can get it out quickly so you can sit down and watch it at your leisure to go through this, because I do think this is an important topic for patients to understand, and you can now hopefully see it with the slides. It'll make more sense. Thanks so much. Thank you.